اوكي بارك الله فيكم. We should start ان شاء الله. بسم الله الرحمن الرحيم. معكم اولا welcome to the International Network of Algerian Scientists. This is a first time meeting for Algerian doctors and هذه الشبكة العالمية للعلماء الجزائريين. The agenda for today is presentation, small one, a short one, from يوسف بوزيد أنايا رئيس مجلس إدارة الشبكة العالمية للعلماء الجزائريين. Second one, it will be a small introduction by Dr. Rashid Dawi. Ustad Rashid Dawi, he will present our guest, Dr. McDERMOTT Brian. And Dr. McDERMOTT, he will talk to us about the COVID-19 management therapy guidelines. Ustad or Dr. Rashid also will talk to us about some new techniques in dealing with ventilation. After that, we will do Q&A and we will conclude, inshallah. So I believe the agenda is clear. So briefly, إيناس هي it's written in English بصح راح نحاول نشرح بالعربية. إيناس هي منظمة غير ربحية تشكلت في أمريكا من بمساعدة مجموعة من الأساتذة منذ يعني 3 أو 4 سنوات. الهدف تاعها هو أنها تكون عبارة عن جسر تواصل بين الخبراء الجزائريين والباحثين في كل أنحاء العالم. يعني حتى عندنا طلبة وعندنا يعني علماء باحثين. الهدف تاعها هو إيصال الخبرة وتبادلها على يعني أسهل طريقة كما رانا نشوفوا اليوم باستعمال هذه الوسائل التقنية، بحيث أنه نسمح ونعاون الجزائر في المستقبل أنها ترتقي كما البلدان المتقدمة. إيناس كأي مؤسسة عندها departments. يعني إيناس inside has IT, communication, finance, عندها legal, marketing, extra. On the right side, Ines is working on strategic project. عندها مشاريع استراتيجية.
Ustad Yusuf, sorry brother, we are not here. We are not seeing your screen. Are you sharing slides?
I am sharing slides.
Yeah, we are not seeing your screen.
Yeah, we are not seeing it, Buzin.
Let me see what's going on here. Just a second.
You can just unshare and reshare again, and it should work.
What about now?
Yes, now it's fine.
So yes, so I'm sorry again. This was the agenda. This is vision and mission of إيناس. كما قلت الهدف تاع إيناس هو إيصال التجارب والخبرة للجزائريين أينما كانوا بحيث تكون جسر تواصل. هذه الأمور مكتوبة على الموقع تاعنا إن شاء الله أو share it with you إن شاء الله in the end. إيناس كمؤسسة قلت عندها departments، عندها IT, communication, finance, legal، وفي نفس الوقت إيناس تشتغل على مشاريع استراتيجية منها ال IT education، الرعاية الصحية، الهيلث كير إلى غيرها. والأستاذ رشيد الحمد لله he is in charge of our health care يعني project. هذا المشاريع راح تشوفوا إن شاء الله بالاحتكاك مع إيناس بأنها مشاريع طويلة المدى. يعني it's a long term project and projects وتحتاج منا إن شاء الله صبر وعمل. إيناس عندها يعني members. هذه الصورة خذيناها العام اللي فات في الملتقى تاع إيناس في فرجينيا، ولكن our members are يعني راهم تقريبا من مختلف القارات. عندنا يعني members from Japan, from Malaysia, from Canada, from America, from أكيد من الجزائر ومن أوروبا. فسريعا فقط راح نتكلم على الحاجة اللي تميز إيناس. هو إيناس عندها very advanced and professional platform. maybe why we are talking like this now because تشوفوا وش قال الأستاذ رشيد. هذه البداية فقط، ولكن اللي راهو جاي هو المهم. فإيناس عندها بلاتفورم اسمها يامر اللي هي عبارة عن social media platform تشبه الفيسبوك صح. it's more professional, it's only for members. ويعني to join إيناس it's free يعني باطل وسريع. يعني it's a very quick process تاع يومين ولا الإنسان يولي عنده access. وتقدر لهنا مثلا يقدر الناس يطرحوا حالات كما الأستاذ براين شيرين new protocol and everything. For INAS we have another tool اسمه Teams. هذا Teams يخلي الناس يقدروا يديروا هو سكايب originally كان سكايب. Teams وش يخلي الناس يتواصلوا in video conferencing and share cases share يعني live ونقدروا 5 حتى 200 يقدروا يكونوا in the same room. To join INAS سريعا to join INAS يعني INAS راهي في الفيسبوك. عندنا ويب سايت تاعنا algerianscientistforum.org LinkedIn and Facebook. and هذه الابليكاسيون اللي الانسان يقدر يعمرها algerianscientistforum.org/become member. Maybe our IT can share it on our platform. So this is briefly what is our organization. Now I'm going to pass it to Dr. Rashid to make his second introduction inshallah. Usama, can you give ولا تفضل أستاذ رشيد, since you are not sharing anything, we will give it straight to أستاذ to Dr. Brian after that. تفضل أستاذ رشيد.
السلام عليكم أيها الإخوة والأخوات في الجزائر داخل الجزائر وخارج الجزائر. السلام عليكم أيها الأطباء والأفاضل وكل الطاقم الطبي ومرحبا بكم في هذا الملتقى الأول الطبي اورغانيزي بار ليناس. وكما الاخ بوزيد قال لكم الاهداف تاع ليناس. قبل ما نزيد شويه بغينا نشكر كل الاطباء الجزائريين اللي راهم في الداخل كل طاقم الطبي في الجزائر، الممرضين، لي فارماسيست، وكل انسان اللي راه يحاول باه يساعد الجزائريين وخاصه مع هذا الكورونا فيروس. ورانا عارفين بلي الامكانيات تاعكم قلال وحنا رانا متضررين، حنا رانا في الخارج ورانا متضررين. وهذه فرصه ان شاء الله باه حنا نستغلوها نخدموا في رحبه ونعاونوا البلاد تاعنا ان شاء الله. هذه الجول تاع الاناس هو تو كرييت دي بريدج ولا دي بون مع لي سيونتيفيك الجيريان في الخارج ولي سيونتيفيك الجيريان في الداخل. ان سيونتيفيك في الخارج وحده ينجم يكتب بكتوب وكاع، بس غادي يكون وحده ما عندش بصح حنا شنو بغينا نديرو؟ حنا بغينا نديرو كل حاجه اللي نجمو نديروها في الخارج يخص البينيفيت تاعها يكون على بلادنا والبينيفيت على الاطباء الجزائريين وعلى وهذاك البينيفيت ان شاء الله يولي الجزائري البسيط غادي يستفاد منه. هذا وعندنا ماتنو عندنا اون بلاتفورم نجمو on va discuter, on va développer des projets à long terme ان شاء الله. وماذا بكم كلكم الاطباء لي فارماسيست وكل واحد في الجزائر باه يجوا معنا يجوين ايناس وباه ان شاء الله نخدموا في رحبه. لو موند حاليا est en face à une pandémie. Le coronavirus est en train de se propager jour et nuit. في les États-Unis عندنا 100,000 cases. في les 24 heures اللي فاتوا عندنا 18,000 cases in the last 24 hours. في الجزائر على حسب التقرير على حسب المعلومات البارح جي سي بان شي سؤال وقال فيها 409 مالات بالكورونا فيروس وفيها 27 ولا 29 داث وفيات in Algeria. إيناس invité دكتور براين ماكديرموت، هو طبيب مختص، هو رئيس قسم لي مالادي انفكسيوز في ساراتوغا هوسبيتال، يخدم معايا هنا في المستشفى ونخدموا في رحبه في صافي 16 عام نخدموا في رحبه. سي هو كي اون شارج دي كاع لي بروتوكول كي عندهم in regard of the coronavirus البروتوكول في ساراتوغا هوسبيتال. والدكتور براين ماكديرموت غادي يقدم لنا ان بريزونطاسيون كونسيرنون لو مانجمنت اوف كوفيد-19 ولا الكورونا فيروس. ان بلا ما نطول عليكم اني غادي نشكر براين ماكديرموت وني غادي نطلب منه بيبدا البريزونطاسيون. Without further ado, and on behalf of the international network of Algerian scientists, I would like to thank Dr. Brian McDermott, and I would like to welcome him for being with us today and for giving us this talk on weekend. And so Brian, I will really thank you for your contribution and for all the effort that you are making. And uh, Dr. McDermott. He's the chief of the infectious disease department, Saratoga Hospital, and he will be starting the presentation, inshallah. Dr. Brian غادي يبدأ, inshallah. Go ahead, Brian.
Thank you, Rashid. I very much appreciate the opportunity to come and speak with you and your organization, and I appreciate Dr. Rashid's trust and faith in me to do a good job, and I hope I live up to both his and your expectations as we.
Thank you, Brian.
And so, without further ado, I will try and start. My goal is to share a little bit with you on the state of the virus in the world, and then a little bit about what we're doing about it. Upstate.
I'm sorry, I gave you access to share. You can share your screen if you want.
Okay. Oh, okay. So let's. Can you see me now? Okay.
Yes. Now it came. Yeah. Now we can see.
Okay. So again, I will try and tell you a little bit as far as I know about where the virus is in the world today, and then again what we're doing about it in our little region of the world. So without further ado, I will start with a little bit of statistics. So even these statistics are from last evening, and in that time, the numbers still continue to grow. So there are over 600,000 cases reported confirmed in the world today. It's over 25,000 deaths, giving a case fatality or a death rate of 4% at least. The United States likes to believe that it's best at just about everything, and we have to make a point of being number one in coronavirus, it seems. And so we now have the leading number one highest count of confirmed cases so far, with over 100,000. We have over 1,500 deaths, and because we're doing a good amount of testing at this point, although we did come with a slow start, our death rate is on the lower side. I don't think that is a reflection of superior care. I think that is a reflection of more accurately obtaining a denominator of milder cases, whereas other countries who have not had the opportunity to test as aggressively are only capturing the sickest patients. Their denominator does not reflect the total number of cases in their country, and therefore their death rates are looking higher. Right behind the United States is Italy, which Italy has been one of the most prominent countries to be reported to date in terms of the severity of coronavirus. They have over 9,000 fatalities so far, giving them a death rate for the cases that they've found of over 10%, or at least 10% at this point, which, again, in my mind, is really a reflection of the fact that they have not adequately tested their community. And so their actual, if they have 86,000 confirmed cases, they probably have close to 1 million actual cases in their country. China was the first country, as everybody knows, and has largely contained their outbreak at this point, and their case counts have been relatively stable now and not extended much above 80,000 to date. One of the standout countries in terms of their response has been South Korea, the Republic of Korea. They started aggressive testing very early on and have had near complete control of their virus at this point without ever having a horrible outbreak like the rest of the world is experiencing. And by doing that, they were able to contain their cases to only less than 10,000 and less than 139 deaths. I think this is one of the, I put this up here because I think this is one of the illustrations of what the true severity of this infection is in terms of how fatal it is. So South Korea is the country that has done the best job of checking the community in a real-time situation to understand what their real prevalence of disease is in their community. So they've captured most of the minor and mild cases of disease to have what I think is probably the closest to a true denominator in order to see how fatal the disease is. So if they're getting 1.5%, that's probably the closest to a true understanding of how fatal coronavirus is. To put that in perspective, influenza in the United States, in its worst season in the last decade, had a fatality rate of 0.14. So that would make coronavirus about 10 times more fatal to have than the typical flu season. So again, that's one of the reasons why this is so important, is because we take the flu for granted every year, but this is 10 times as fatal as the flu. And then specific to our conversations today, the reported numbers for Algeria so far are 409 confirmed cases and 26 deaths, with a death rate of 6.4%, which again is probably an overestimate of the fatality rate, because there are probably many more cases in the community that have not been not been tested and identified. So what do we do about all this? Right? So we as physicians, we take care of sick people. And one of the best ways to defeat this virus is to intervene before our skill sets are even needed, which is preventing disease from having happened in the first place. So primary prevention, which is separating disease from disease-free people to stop the spread of the disease. One of the best illustrations of how to do this was published this week in the New Yorker magazine by Atul Gawande, who is a surgeon and medical literary writer, reporter, and researcher at Massachusetts General Hospital in Boston, New York, who wrote a piece summarizing the risks to healthcare workers and a little summary of what some of the other exceptional countries have done and regions have done to control the virus. In particular, he focused on Singapore and Hong Kong, which on a smaller scale than South Korea have done an extraordinary job of containing this virus in their regions and never getting to the point of having a pandemic outbreak. So I put the link here so that everybody has access to this. It is free, and I suggest that everybody take a look at this in their spare time. The importance of this article is in showing how very low technology, low resource interventions make the biggest difference. So in Singapore and Hong Kong, they did not use negative pressure isolation rooms to contain virus. They did not use N95 respirators to prevent aerosolized transmission. Nobody was wearing face shields. Their defenses for healthcare workers were simple: surgical mask, gowns and gloves, and extensive hand washing. And with that, they protected their own. Their healthcare workers have zero transmitted sick patient to healthcare worker transmission of disease in these regions in the world by strict adherence to very simple things that are reproducible anywhere in the world, such as Algeria. So I highly recommend everyone review the techniques that were done there to keep our healthcare workers safe, because if our healthcare workers are not safe, we will not be there to be able to help our patients. So with that said, what are the other strategies that are being? So number one is social distancing. This has taken on large scale and small scale efforts. Small scale efforts starting from everybody trying to not touch each other. Right? We have as a society, socialization and close contact with friends, family, and professional contacts is a way of life. Shaking hands, hugging, kissing, sharing meals together. All these things are natural courses of life that bring us all together and make us friends, family, and coworkers. Plans today are to say we need to adjust that expectation, and for the next period of time, say we need to stop these activities, because these are the activities that, unbeknownst to us, spread the virus from one to another. And we're trying to break that cycle. Coronavirus is a droplet spread infection. It is like every other coronavirus or rhinovirus or common cold causing virus. And so it is spread largely by droplets, meaning it is in an infected person's mucous membranes. And when they touch their face, touch a door handle, touch a refrigerator, touch a countertop, touch the computer, or touch you, and then the next time you touch one of those items and then touch your mucous membranes, your eyes, your mouth, your nose, then you end up being infected. Yes, this is also spread by sneezing and coughing in more symptomatic patients. And again, they spread the virus in those droplet particles that are expectorated onto surfaces around them to then touch. Trying to break that cycle by keeping everybody apart so that there's less opportunity for it to happen is core key to doing this. That's on the small scale. On the larger scale, right, it is avoiding group gatherings. So I know in Algeria, there are routine protests, and that as a country decided to suspend protesting in light of coronavirus, which I know nobody wants to stop protesting, but for the greater health of the country is the wrong decision to make at this point. And by not putting thousands of people in close contact to each other, we help to reduce the spread and likelihood that these organisms will be spread from one person to another, making us all sick. The other core tenet is testing. And so having good access to testing helps identify those patients who are actually sick with coronavirus versus other respiratory infections, so that then appropriate quarantining can be performed. That said, some countries such as South Korea have invested heavily in testing and have tested hundreds of thousands of people at this point in order to understand who is sick and who is not, in order to enforce their quarantining positions. That is important, but it is not as essential as some of the other things that we're talking about. And I'll show you why in China's specific example in another few slides. So don't feel if you do not have access to good testing, that you still can't make a difference in this pandemic. Quarantine is another key feature of breaking the cycle. So patients who are known positive and their close contacts should be isolated for 2 weeks. Again, this is taking the social distancing to an extreme, saying not only do we not want asymptomatic people to keep away from each other to reduce spread, but those who are known to be positive really need to stay away from everybody else, because the people that you're closest in contact with are the most likely to be infected. So having a higher threshold for known positives and their close contacts to stay away from everybody else until the disease either passes or they come through it without showing symptoms. Fourth is the personal protective equipment that I referred to in the prior slide. And again, very simple things are very effective. We don't need high-tech equipment to keep us safe from this infection. A simple mask, simple gloves, a gown if possible, are all that are really needed to, in terms of healthcare workers, of keeping themselves safe so that they neither become a vector of disease and don't become victims of the disease. That, combined with good hand hygiene, are the core principles of keeping ourselves and our patients safe. So frequent hand washing with soap or an alcohol-based rub, if available, are all highly effective ways of preventing the spread of infection. Why are we doing all this? So why are we doing all this is to slow the spread of the infection. We call this flattening the curve. So you can see the yellow graph there to the left is an example, say, of what Italy is facing right now. They did not recognize in time that they were having an overwhelming number of cases of infection. And what that did was give them quickly a surge of cases of high severity that overwhelmed their healthcare system to the point that they did not have the sufficient healthcare resources to be able to take care of all their patients and all their citizens to the point they wanted in a time frame that was timely. And again, that part of that goes to their excessive death rate, is that they did not have the resources to take care of the sickest patients when the sickest patients needed them. These are the issues that we're facing in New York, in the United States right now, in New York City, that they are approaching capacity and they're doing everything they can to expand their capacity and resource themselves to be able to sustain what is right around the corner and about to come. So the goal of all these isolation methods that we just spoke about are to change the course of the disease from the yellow graph to the green graph. Right? You want to slow, it doesn't mean that we're not going to still have lots of infection, but we want to slow the rate of infections over a longer period of time by distancing ourselves from each other to limit the number of cases that come all at once, so that when people do get sick enough to come to the hospital, that we have the ability and the manpower and the resources in our facilities to be able to take care of the sickest patients. Now, I use this graph here. This was an article published last month in the Journal of American, from the American Medical Association, that summarized the early course of disease in Wuhan, China. And the things that I want to show are two things. One, there was a new respiratory virus that a very astute Chinese physician noticed. They quickly mobilized their own public health resources and identified this virus, all here in the early parts of the disease. Quickly, in about 1 month, they were able to find that there was a new virus, identify that virus, and report it to the world. Now you see, the green line here is the number of new cases that they were having. So this right here is when they enforced a strict quarantine of the whole region, right? And as soon as they instituted a complete halt of all social interaction, the case rate dropped, right? And it took about a month for them to go from having uncontrolled growth to a slow exponential decrease in cases, now to the point that they have started to allow free movement again in China. This is important for two reasons. One, it shows that the real change that they made was the change in social interaction and the social distancing and the quarantine, but really to their epidemic. The yellow lines here indicate when they actually did the testing. So they were the first people to do this, so their test was delayed. So they actually made the changes in their society that led to a change in their epidemic before they actually had the test results. So my point being, testing is important, but testing is not everything. They were able to change the course of their disease without having test results in real time. So again, for a country like Algeria, do not feel that you cannot make a difference in your disease if you do not have access to testing. It is still possible to defeat this epidemic without real-time testing. That's my main reason for showing this graph. Next, these ideas did not come out of nowhere. Right? So here is an example of from 100 years ago, where the idea of social distancing and quarantine were put to good use and have been shown to work in the situation 100 years ago. So in the 1918 influenza epidemic that went around the world and killed millions of people, and in fact, the case fatality rate for that year's influenza was noted to be about 3%. And that was before antibiotics, that was before ventilators, that was before anything other than supportive care was available. So that was huge. Now, in 1918, in the United States, World War I had just ended, and soldiers were returning home to the United States, and the United States wanted to have lots of big celebrations and parades to recognize the returning soldiers coming back from war. This happened right at exactly at the same time that the influenza pandemic was coming to the United States. 2 representative cities, one Philadelphia, one St. Louis. Philadelphia knew the virus was coming and decided that they were going to all go out and celebrate, and they had big parades and week-long celebration. And as soon as that happened, everybody in the city was getting sick with influenza, and their death rate climbed dramatically. And they had huge losses in the city of Philadelphia of young people who all got sick and died from influenza because they had close social interactions with large groups of people, and uncontrolled spread of disease was the result. In contrast, in St. Louis, in the United States, they saw the same things, knew the virus was coming, and instead of having parades, they put everybody on lockdown orders. They quarantined everybody at home, and everybody stay at home for just not for a long time, only about 2 weeks. They shut down all transportation, all businesses they had to close, and the wave of influenza passed over St. Louis, and they lived through that largely unscathed. To have a distribution in that dotted line that looks more like a normal average influenza season curve that you would expect with a small peak in the winter. So it is possible that these methods are tried and true and have proof of cure from over 100 years ago, again, using simple, low technology things that do not require high-priced, high-technology medications or interventions as health providers in order to save our population. So now I'm going to try and go live to some things on the internet here. See if I can show you. Here's the best website to date on coronavirus. The Johns Hopkins University has summarized all the statistics from the whole world on a daily basis. So even from last night, you can see that the total cases confirmed has gone up by almost 20,000. The reason that I put this up here are to look at these graphs in the lower right-hand corner. So this is the daily increase in number of cases. So it has only been in the last several weeks that the world has really taken seriously the idea of social distancing and sheltering in place and shutting things down. And you can see that just in the last 2 weeks here, that the case rate appears to be starting to flatten. And so that's for the whole world. In the United States, same thing, right? It was only about 2 weeks ago that New York put everybody on pause and made everybody stay home and closed all the schools and closed most of the businesses. And you can see that the case rate in the United States has started to bend its curve, just like. So I have I'm hopeful that all these interventions are making the difference that we're looking for. Again, Italy, same thing. China, you can see China did the same thing as per that graph that I showed earlier from the JAMA article. By implementing their quarantine, their case rate dropped dramatically. You can see the same thing for all the other countries that are going through the same thing. I won't spend any more time on this. We'll go back to the presentation. So again, I put this site up as your resource, as one of the sources of truth to go to that will give you the most up-to-date and most accurate information of what's happening in the world that refers to coronavirus. So now switching gears from the disease as an epidemiology study to the disease presentation in terms of our medical care as a doctor. So the average incubation period is from about 2 to 14 days. And again, there was a good study that showed that the average mean onset of illness is about 5 days. The initial presentation is largely specific, just like every other respiratory infection: fever, dyspnea, cough. Those things are fairly standard, non-specific. One of the new incidental findings that is a loss of taste or smell. So if patients come to you and say, you know, I don't feel good, and suddenly I can't smell my coffee in the morning, or I can't taste my coffee anymore when I get up in the morning, something that normally would have a robust, prominent taste or smell, and suddenly they say, I can't taste it. keep that in your mind as a key indicator that that has a high likelihood of being coronavirus. The thing that makes coronavirus different than other respiratory infections is after this first symptomatic period of typically 5 to 7 days, patients who are going on to develop severe disease are going to develop a progressive hypoxia that then can become quite serious. So again, initial prodrome that's fairly nonspecific with a febrile upper respiratory symptoms, followed by an interval of about almost a week, which then progresses to severe infection. What do we find? Again, hypoxia being one of the key elements of this illness. And often healthy people are minimally symptomatic. So you have a young 30-year-old with no comorbidities who comes in, and you do a pulse ox on them and you find that they're 84% walking around saying, yeah, I'm a little short of breath, where you would expect they would be horribly winded and not able to move. Other non-specific lab findings that are all consistent with this infection would be relative lymphopenia. And relative lymphopenia is a common finding in viral illnesses in general. And in general, the more profound your relative lymphopenia, meaning if you have 1, 2, 3% lymphocytes on your CBC, that the more profound your lymphopenia, the more your likelihood that you're going to have severe disease. Mild leukopenia and thrombocytopenia is common. Mildly elevated liver tests, mildly elevated CRP, a D-dimer, ferritin. These are all inflammatory markers that are consistent with viral infections. Procalcitonin is typically not elevated, consistent again with a viral infection. If you have a high procalcitonin, they may have COVID, but I would also look for a superimposed bacterial infection, either pneumonia or some other infection. That's not elevated procalcitonin would not be consistent with coronavirus. And the most noticeable finding that was mentioned earlier, which was discovered early on, is the finding of ground glass opacities in the lungs. Early on, this may be unilateral. By the time people are getting more sick, it is bilateral, usually peripherally rather than centrally located. What can we do about coronavirus? This is some of the most frustrating parts of the whole disease, is that there's very little that we can do. So 80% of people are going to have a minor disease, and they only require supportive care. So most people can be isolated back to their home and monitored, told to return if they have worsening symptoms. Again, look for that initial non-specific illness with a higher percentage of people who would then represent after diagnosis a week later with worsening hypoxia. The people will progress after a week to more severe disease. And again, as I said, progressive hypoxia to the point of having respiratory failure. That respiratory failure is in a pattern consistent with ARDS. And when things get really bad, they develop a cytokine storm that gives multi-organ system failure and ultimately leads to death. These are the worst cases of all. And again, the percentage is rather small. Of the 20% that are moderate to severe, maybe 5% are critical, 2.5% ending up on the ventilator, and then seeing the death rates that we were talking about earlier. In terms of oxygen therapy, we have lots of modalities for oxygen therapy. Obviously, people who have a low-level hypoxia be stable on a few liters nasal cannula. High-flow oxygen systems are being used, whatever kind you may have, whether you have a Vapotherm or other brand names. Principles are all the same. There have been lots of concerns over aerosolization with higher flow oxygen systems. Is that really true? Is that just a theoretical possibility? The answer is nobody really knows. Overall, the risk is considered quite low in terms of using a closed-based high-flow system in terms of risk to healthcare workers for aerosolization. And again, BiPAP is typically so far not highly recommended, as the primary problem is hypoxia, not typically hypercapnia, so BiPAP is not going to help. Over a high flow system, typically CPAP may be a good choice in certain individuals, but overall, there has been a push for early intubation of people who are at high risk, knowing that many of the people who are having progressive oxygen demands are not going to escape this without intubation if they're available, because that is the next limiting factor, is whether there are enough ventilators in the world to take care of all the critical patients. Will we be able to handle the volumes of respiratory failure that are expected to come? In terms of ventilator management, for people who do progress to that point, an ALDS related approach to ventilator management is what is becoming the standard, meaning low tidal volumes with a high PEEP. The lung becomes a problem as respiratory failure progresses, allowing permissive hypercapnia to maintain those low volumes and high PEEP. In general, avoiding steroids. I think this is a recommendation, not so much because anybody has shown that steroids have a horribly adverse effect, but just that in general, steroids for viral pneumonias are not proven. The ARDS really have no data to suggest that they are overly effective. Most of these patients are presenting in the United States and are meeting criteria for our sepsis protocols, which demand a very high volume fluid resuscitation. That is being shown to not be particularly helpful. So minimal to mild fluid resuscitation is usually the norm of what is needed, and just giving everybody 3 liters of normal saline, just because that's what the guideline says, is not proving to be particularly helpful. Prone positioning for vent management is one of the things that has helped oxygenation, and for those places that have the technology to do ECMO, this is a modality that is being used with fairly good success. There are a few good studies so far, both from China and from Seattle, on the early people who have been ventilated with an average number of days on the ventilator for people who are surviving, requiring 10 or 11 days, which is a fairly long time to be on the ventilator. The most innovative things that are being talked about and utilized right now for ventilator management, and when we have a shortage of ventilators, such as in Italy now, are ways to manage multiple patients on one ventilator, 2 or 4 patients on the same ventilator. We've not done that in our hospital to this date, but we have at least figured out how we would do it. And again, there are many limitations on how to do that. The patients would have to have roughly the same size so that they would tolerate the same tidal volumes and the same PEEP. There would be problems if patients' lungs have different compliance. If one patient's lungs have more compliance, the others less. The one with the better lungs are going to end up getting more oxygen, and so there's a lot of potential for mismatch. But this is the way that people are starting to talk about how to make ventilator management possible for the large numbers that are expected. Has happened actually in Italy and are expected to be happening in New York very near future. So more to come on multiple patients on one ventilator. Again, the risks are, in addition to do you get their oxygenation right, is they're on a shared circuit. There are talks about filters, but the risk of having a ventilator-associated pneumonia would be higher in terms of sharing bacteria and pathogens between patients on the same vent. Pharmacologic interventions. This is what everybody's been talking about to date, and the honest answer is no treatment so far has shown to have any conclusive benefit, but there's lots of things that are being talked about. Right? So the number one thing that's being touted is remdesivir, which was first brought up to use as a possible Ebola drug and is now being trialed around the world for coronavirus. Studies to date, every study has everybody can refer to any one of these interventions and show that there's a study that says it's good. There's also no shortage of studies that say that all these things can be bad. So I think there's so far no consensus on any treatment options as being good or bad. But many things are being tried and trialed, both in legitimate studies as well as just anecdotally, because that's all we have to date. So again, remdesivir is an antiviral that was first used for Ebola. The second is favipiravir, which is an influenza drug from Japan that is being trialed. That's had early adoption in China and is being tried in other places around the world. This is not available in the United States. The things that everybody are really looking forward for as their big mainstay hope are either chloroquine or hydroxychloroquine, plus or minus Zithromax. And like I said, there are risks and benefits to all of these. The azithromycin portion of this is probably largely has little downside. And if it has any benefit, it's probably from its anti-inflammatory properties. And chloroquine may be an option for Algeria, as that may be more readily available. Hydroxychloroquine as well, both of these having the potential of being efficacious, but at this point, nobody knows. There's risks of giving it too early, there's risks of giving it too late. They all have side effects. They all extend QT prolongation. So there are several considerations before you just empirically give these things to everybody. G6PD deficiencies, knowing that or not knowing that ahead of time, all put patients at risk of adverse events. So please consider using with care. Kaletra, which is lopinavir ritonavir, is an HIV medication. There was a good study published in the New England Journal of Medicine a week or two ago, which really showed that this had no effect on outcomes. So this is on about the bottom of the list of things that are being tried. But this and other HIV-related medications, along with some interferon combinations, are in study as we speak. One of the things that does hold some promise for the very sickest patients is tocilizumab, which is Actemra. This is a biologic that inhibits the IL-6 pathway. And so for those severely ill patients who are going on to develop cytokine storm, this is one of the things that theoretically can shut down those pathways by turning off one of the early indicators of that, which is IL-6. And if IL-6 is inhibited, then the rest of the cascade technically or theoretically would not continue. So that is being trialed as well around the world. I have not used it yet, but we've made sure that we have some available in our hospital if we need it. And with that, I will end at this point and turn it back to the moderator for questions.
Rashid, you're on mute.
Hello?
Go ahead, Rashid. We can hear
Okay,
you.
good. Brian, again, on behalf of the International Network of Algerian Scientists, I would like to thank you again, and all the attendees are thanking you for the wonderful presentation that you had, and with the up-to-date information. So we're going to open the floor for questions. Pour l'audience, شكرت براين باسمكم وباسم الاورغانيزاسيون على البريزونطاسيون الممتازه avec les informations current ودقيقه وحاليا open the floor pour les questions. واحد اللي عنده سؤال يسقسو براين. I want to ask السؤال تاعي للاتندي. If you want, إذا حبيتوا نجم ندير un résumé نتاع what Brian a présenté. What do you think, Bouzid?
أكيد تفضل أستاذ.
I would like to thank Dr. Brian as well for his time and for all the information that he provided. Thank you so much, Doctor. We really appreciate it. And for the audience, I do agree with Dr. Dawi that maybe Dr. Dawi, if you can summarize what Dr. Brian has explained. As well, we were planning 1 hour for this, but looks like I had some requests on the side asking to extend this because looks like people may have questions. So I would leave it to you, Dr. McDermott and Dr. Dawi. It's up to your time. We're your guest here, so if you have time, please, and we can extend this more than because it looks like it's already 55 minutes and people are still having questions. Dr. Dawi, it's yours. You can summarize, and we will start after that with the questions in the chat.
Okay, yeah. Brian, do you have any objection if we extend this by at least 30 minutes?
That's fine.
Okay, yeah. I'm on call, but I think I can make it. I can. Yeah. So في بندير summary نخيط غير لي بوين اللي عندهم امباكت بالغ على الجزائر ان شاء الله. سو لا بريمير summary اللي قالها لا بريزونطاسيون الاولى سي لو تو دو مورتاليتي في العالم اللي كو براين هي ديسكرايب في كان لو توتال تاع لي كيس في العالم نتاع الكورونا فيروس سي ابوبري 600,000 cas de coronavirus où le total mortality rate في العالم c'est 4,6%. And في les États-Unis كان 103 100,000 cas. في les 24 اللي فاتوا كما قلت لكم في les États-Unis كان 18,000 cas. في الجزائر كان 409 كان 409 وكان le taux de décès c'est le 26. La mortalité rate في الجزائر c'est 6.4. في l'Italie c'est la mortalité rate, le taux de décès c'est 10%. والدكتور ماكديرموت شرح لنا علاه قال لك باسكو في l'Italie من l'épidémie بدات ils n'ont pas testé les malades وما داروش l'isolation la distance sociale ou le quarantine parce que في l'Italie c'est comme les Algériens يبغوا لي جون يتحاكوا زعما يتلاقوا ونسالموا على بعضنا بعض على هذه كانوا هما اون روتار ومن بعد lorsqu'ils ont commencé à tester بيديروا لي تيست و ils ont commencé ثاني d'instaurer la quarantaine c'était too late c'était vraiment il était à un stade avancé وش داروا كاينه that curve flatten the curve هذيك la curve هما كانوا في early disease but they were not n'étaient pas able to contrôler la transmission de la maladie. Dans ce cas ils ont saturé ils ont dépassé les possibilités اللي عندهم في الكريتيكال كير في la réanimation. They overwhelmed their healthcare system. Ils ont super saturé. Ils n'avaient pas enough les moyens pour faire face à cette épidémie parce qu'ils ont commencé late and ils n'ont pas testé. And so that's هذه. See. كان un article ثاني براين هدر عليه سي il a été publié في نيويوركر وهذاك l'article a démontré qu'avec des simples mesures on peut contrôler la transmission de la maladie ou surtout في الهيلث كير وركر surtout في les médecins ou les pharmacistes قال لك في l'étude اللي اندارت البوبليكاسيون اللي اندارت les gens n'avaient pas besoin de des choses sophistiquées. Ce qu'ils avaient besoin d'un masque, des gloves, des gants ou des surgical يلبسوا حاجة pour les isoler وثاني ils avaient besoin ils ont de hand washing ils ont lavé leurs mains constamment غير بهذو les mesures avec le face mask ou hand washing ils ont pu diminuer la transmission نتاع le coronavirus وهذه زعما without testing بلا داروا تيست. ثاني كاين هذه لا كيرف نتاع l'épidémie نتاع الفلو épidémie 1918 هذيك صا امباكت ثاني الجزائر هذه الكيرف شفتوا الكيرف كاين في 1918 من بعد لا بريمير غير مونديال لي تروب امريكان ولاو لي ستازوني وحدين راحوا لفيلادلفيا وحدين راحوا سانت لويس اللي راحوا فيلادلفيا داروا دي فيستيفيتي داروا حفلات وكاع وفي durant l'épidémie la plupart كان عندهم un mortalité un taux de mortalité très élevé. Les gens اللي راحوا لسانت لويس ما داروش لا فيت وفي سانت لويس they quarantine ils ont isolé les malades وداروا social distancing قالوا لي جون قعدوا في دياركم وشتوا لي جون اللي جاو من لا بريمير غير مونديال لو طو تاعهم لو طو ديسي تاعهم كان طري با. كان ثاني حاجه ان كيرف دكتور براين ماكديرموت وراها سي الكيرف تاع تشاينا هذيك عندها ان امباكت على الجزائر. شفتوا في الديبي تاع الكيرف هذاك دكتور لي le médecin chinese so le premier mois il a essayé d'alerter les autorités chinese بلي كاينه ان فيروس جديد. واش هما ils l'ont ignoré بصح من بعد دات لهم ان موا سeulement تو باه يديروا كارونتين الاريا اللي جا منها الفيروس. خلوا ils ont obligé les gens بيقعدوا في ديارهم حبسوا لي سكول حبسوا ترانسبورتاسيون ومن بعد ان موا ابري شفتوا الكيرف ولا تهود ils ont pu contrôler la transmission du virus avant même d'instaurer un testing de masse. So ils ont agi même avant بيكون عندهم لي فاسيليتي دو تيستي تو لي مالاد. سو هذه تنجم تساعد الجزائر. سي لا سيباراسيون سوسيال سي لا كارونتين الهاند هايجين لافي لي مان وهذه ذن لي ومن بعد دكتور براين ماكديرموت هضر على كي نديروا بان كونترول الفيروس كونسيديرينغ ذا الجزائر 40 مليون وما عندناش البوسيبيليتي تيستينغ وعندنا مشاكل كبار في الهيلث كير سيستم تاعنا. قال هو قال باللي كاين دي مويان qui ne sont pas sophistiqués où tu peux faire une différence. social distancing هو الانسان ما يتلاقاش مع الجماعه تاعه وما يديش الحفلات ما كاش يسلم على بعضهم بعض زعما كل واحد يقعد في داره. وثاني كاين الكارونتين فيري امبورتانت. كارونتين من يو ايدنتيفاي واحد بوزيتيف تيزولي هذاك بور 14 جور وثاني ايزولي لي جون اللي كانوا معاهم كونتاكت سيتادير غادي دير ان ايبيديميولوجيك ان ايتود ايبيديميولوجيك وكاع لي جون اللي معاه اللي قربهم اللي كانوا معاه في الدار كاع يكونوا اون كارونتين بور 14 جور تري امبورطون. وهذه وات ماني كونتري did especially Germany ثاني اللي زعما. وهدر ثاني على البي بي اي هما سي لي هدر على لي ماسك وهدر على الهيلث كير وركر قال لك ان سامبل ماسك دي جلوفز الهاند هايجين. ثاني هدر وهدرنا على الفلاتنينغ الكيرف تاع تشاينا social distancing. هدر كذلك على لي سيني نتاع لو كورونا فيروس. سو دكتور براين ماكديرموت قال لانكوباسيون بيريود سي 2 à 14 جور عند وغادي يكون عندك دي لا فييفر لا تو وعندك لو ثاني كان ان ساين نيو سي لو يو لوز لو سونس تاع السمال تيست ما توليش تشم لي مالاد وما توليش تحس من تاكل ما تحس بوالو. وعندنا شفنا مالاد ريسامون ما عنده راح لك على السمال ما ينجمش يشم كاع الريحه ولا حاجه. هذا ستان ساين نتاع الكورونا فايروس. كان نوت ساين دكتور براين ماكديرموت نسيت وهذه مالاد شفناها صافي كالكو جور كانت عندها انسفيزونس رينال في نوتر هوبيتال مشيتها جات انسفيزونس رينال ان دياري سالمون اون لا ايزولي. التيم تاعي شافها اون لا ايزولي باسكو il s'est reporté que la diarrhée كانت تكون ان ساين تاع كورونا فيروس و سيتي اون فاكت عندها سيتي التي بوزيتيف فور كورونا فيروس. سو هذه ثاني ساين. كاين دكتور براين ماكديرموت هضر ثاني على لو سيرج سو المالاد يكون عنده دي سيمبتوم مايلد. قال لك لا بليبار تاع لي مالاد سي 80% غادي يكون عندهم دي مايلد سيمبتوم 20% غادي يكون عند دي سيمبتوم سيفر. هذو خصكم you have to watch them وتشوف الاكسجينيشن تاعهم تشوف other symptom. كاينه حاجه واحده اخرى ثاني للسيرج. قال لك في الدي جور ل 11 جور كاين السيرج تاع السيتوكاين تاع لي سيتوكين لي ميدياتور دو لانفلاماسيون اي ال 6 مش عارف كومون لا ترانسميتر اون فرونسي سمحوا لي اي ال 6 سي اون سيتوكاين وتعطي هذا تعطيك ان سيفير انفلاميشن وهي اللي تعطيك البيكتشر نتاع الاكيوت ريسبيراتوري ديستريس سيندروم، هو اللي تعطيك تاع l'insuffisance respiratoire. Les malades qui sont intubés, les ventilation, many of them they are not going to do well. Spécialement اللي كان عندهم des comorbid condition، اللي كان كبار more than 70 years old وعندهم diabetes، عندهم insuffisance renal، عندهم cardiomyopathy. هذو this type of people they are not going to do well in ICU، مش غادي يديروا مليح في ICU. ثاني دكتور براين ماكديرموت le traitement c'est controversial. ما كاش une étude qui a été faite that show اللي تبين باللي كان ان traitement supérieur على الاخر. هدر على plusieurs type of treatment وهدر على la chloroquine ولا الهيدروكلوروكوينين that بزاف الناس راهم يوتيليزي هذروك. هدر على ثاني الزيتروماكس that also you can use. هدر على des médicaments antiretroviral medication, des médicaments qu'on use for les viral infection. هدر على new médicament اللي كان تالي في السلايد اسمه التوسي ليزومابايد. هذا سي موديولاتور، سي un médicament qui agit sur l'interleukin 6. وين عندك كورونا فيروس عندك لو سيرج 11 days. اما لا كاين ستادي بداوها في certain area في certain hôpitaux ويعطوهم هذا الميديكامون it control it block la reaction induced that induce severe inflammation and so you block the IL-6 وهذه c'est en étude and وهذا ثاني شويه على la ventilation and so هذا just un summary ولكن خاص ومثلا on est open les questions ان شاء الله. So Brian, one question. There is one question that I noticed. So Brian, how we can prepare for the second wave, and why we cannot apply quarantine for 40 days instead of 14 days. So كاينه in deuxième waves كاين deuxième wave اللي غتجي وعلاه ما نديروش وعلاه بوركوا اون نو كارونتين با لي مالاد بور 40 جور. هذا السؤال من دكتور شتوان. بارك الله فيك.
Okay, so a couple things. So a second phase or second wave of epidemic is certainly a concern. And that's so a country like China is ahead of us in terms of it, that they've finished their first wave essentially and are worried about new infections coming up again. And so they've done things like they're not letting anybody else back into their country so that there are not reimportation of cases back in again. I think part of this, there'll be several things. One is will depend on how extensive the first wave really is. So at what point does the community, so if we flatten the curve and still a lot of people get infected, but we are able to handle the volume and most of them get better, right, then we'll have a large percentage of the population that has immunity. Right? And if they have immunity, then the likelihood and ease of transmission therefore decreases significantly as you build up a herd immunity in the population, limiting the spread of the disease. So one is by people getting sick in the first place, it helps limit the effect of the second phase. Number two will be if we can push off the second phase to something more than a year from now, right? We will have some antibody testing, so you can actually test who has disease to to know who might be immune and who's still at risk, so that you can more selectively confine and limit your exposure for those who are still at risk. And hopefully in a year's time or so, we'll also start to have immunization if needed to again protect people from the disease. So I think the real strategies are, again, by flattening that curve and extending the first phase, that we develop some immunity and have means to give ourselves immunity going forward to limit this as a future problem.
Thank you, Brian. So just to traduire a little bit, so la question هي كانت comment شنو غادي نديروا pour faire face à la deuxième phase de l'épidémie. So Dr. Brian McDermott قال بلي premièrement, c'est durant la première phase, on espère que les malades qui étaient atteints, ils vont développer une immunité qui va durer. وهذا غادي تعاون that limit la second phase. وثاني by flattening the curve. هذيك the curve هذيك اللي وريناها لكم كيما l'Italie a été overwhelmed, le système تاعهم a été surpassé. Ils ne pouvaient pas faire face à l'épidémie, à la pandémie, parce qu'ils n'ont pas testé, ils n'ont pas de la quarantaine. So testing, doing quarantine and the hand wash and face mask pour le healthcare worker, and that and quarantine of les malades qui sont positifs et leur famille, les gens اللي كانوا contact معهم, it will flatten the curve. تساعد باه الكيرف تولي في التحسن، لو طو تاعها ما يزيدش. سو هذه لا دوزيام شوز اللي قالها، قال الفاكسيناسيون. قال لك بالك ان شاء الله دون زان نون بالك نكونوا غادي نكون سي بوسيبل بان يكون عندنا فاكسان بان نديرو كونت الكورونا فيروس. Brian, the second question, how to explain the number of critical case in Germany, say just 23 critical case from number of 50,000 patient infected. السؤال للجماعة، علاه في الألمان عندك سلمون 23 مالات في العناية وهما عندهم 50,000 مالات كايتي infected.
So I think there's a couple factors at play here. One is I just looked on the Johns Hopkins website, as I used before, to show everybody. And yes, Germany has a little over 50,000 cases. And it does show that they have more than 23. They've had 399 deaths so far. But still, that gives them a case fatality rate still of less than 1%, which is outstanding. I think there are several factors that can help explain that. One is they're doing a very good job. Right? So they've done several things. One is they're testing a lot of people. So they're isolating patients who are positive, limiting the spread. The other thing is targeted interventions in order to keep the most vulnerable patients safe. So two things that I forgot to say in my talk are who's actually getting the serious illnesses, right? The older you are, the more likely you are to have severe disease, right? So if you're over 70, or 70, 80, 90, those patients are getting severe disease with a high mortality rate. And the more comorbidities you have, so heart disease, hypertension, diabetes, underlying lung disease, immunocompromised patients, those are the patients put that together with old age and your risk of serious disease and or death starts to climb into double digits, 10, 20, 30, up to 50%. So by limiting the spread and really protecting the elderly populations, they can reduce their death rate over much. And the other thing is they're still early in their disease process, and where they are today may not be what their numbers look like in another couple of weeks. So for example, South Korea, which, as I said, has done an excellent job of containing their epidemic, a month ago, right now they have a 1.5% case fatality rate, but a month ago they only showed 0.6 death rate. So I think that over the next month, Germany, which is earlier in its progress of the disease, may have their case fatality rate increase a little bit more to the range that you're seeing for South Korea, for the United States, by the time their numbers are finalized and we see how their total population fares. So I think early on there have been some demonstration of countries doing it well that have numbers that look like Germany's right now, but they may catch up a little bit over the next month or so.
Brian, thank you. So الجواب هو قال لك في en Allemagne le healthcare system تاعهم مليح و les gens ils sont en train de faire un excellent job. Ils sont en train de tester les malades, عندهم les moyens de tester, ou ils sont en train d'isoler les malades qui sont positifs ou les malades ou les gens qui étaient en contact avec la quarantaine. وثاني what they شراهم يديروا, they have targeted intervention. So les gens qui sont vulnérables, les malades اللي عندهم more than 70 ans, les diabétiques, les cardiaques, les insuffisants rénaux, عندهم they target them, they try to protect them, عندهم des mesures pour protéger هذو les malades. وثاني قال لك le taux de mortalité في l'Allemagne il est très bas, less than 0.1%. بس قال لك سي بالك راهم on early stage of the disease, بالك راهم في الديبي نتاع لا مالادي تاعهم. il a pris comme exemple South Korea وقال بلي un mois, le mois passé, le mortality rate تاعهم, le case fatality تاعهم كان 0.6. Un mois après, c'est 1,5%. So بالك الألمان راه في الأرلي فيز وبالك نشوفوا ان شونجمون. بصح en général they are doing great job, they are doing a good job. السؤال
Dr. Rashid, I have a question. Dr. McDermott, I have many questions. Thank you for the talk. We know I'm a neurologist, but I have a question about the virus itself. We know that the virus, when it moves from one person to another, it loses its virulence. Why is not the case in COVID-19, though?
On the virulence of the infection, and I think the real answer is anything I tell you is just made up, and nobody knows for sure. So there are some thoughts of whether the initial virus that hit in the early cases in China was more virulent initially, and as time has gone on, has it become a little less, and does it, have those virulence factors waxed and waned over time in different places? And so does that explain why a place like Italy suddenly may have had earlier virus that was undetected in the community until it got too late, and other places in the world are seeing something a little less? There are discussions of whether household contacts who get secondary spread are a little less severe cases. So I think the jury is out, and a lot more research needs to be done in terms of the virulence factors and changes in the virulence factors of this coronavirus as time progresses, and whether it's going to decrease in virulence in order to, and that will help it spread by, if a disease kills too many people, then it doesn't have the chance to spread. If it doesn't kill as many people as quickly and has more chance to spread, then sometimes its ability to last in the community is greater. So what the coronavirus is going to do yet, I'm not quite sure. There's illustrations of that in things like in other flu-like illnesses, some of the avian flus that have come out, that when they make the transition from animal to human are very deadly, but then they quickly burn themselves out because because they're so virulent that they don't have time to spread person to person. So where coronavirus is in that spectrum yet, I think a lot more work has to be done.
Thank you.
So the next, Bouzid, I don't see the question on the screen, but I have it on my phone. Brian, one question. Are the low number of cases recorded in Algeria is it due only to the lack of more global testing? So that's one of the questions. They say
Right.
why there is just only 406 patients and we are 40 million, and we have the same type. We have the same type of social life than other
Yeah.
Mediterranean countries such as Italy.
Right. So I don't think it's due to lack of testing at this point. I think it's that the disease is clustering in certain areas earlier than in others. So I think you still do not have a large amount of disease prevalence in your community, which is good. So now that the world has woken up to the fact that this is a pandemic and everybody needs to do something about it, Algeria is well positioned to take control of its situation while it still can. So, for example, in New York, where the positivity rate of testing is over 25%, too late. It's largely too late for them to stop that exponential growth without a lot more people getting sick. Whereas in Algeria, if you have a very low, less than 1% positivity rate in people who are presenting with respiratory infections, and you're going to implement the same level of social distancing and quarantine and canceling large group events, now is the time that you can keep that rate a very low rate so that you never get to the point of crisis that other places like New York and Italy and China have been in the world, and hopefully come through this largely unscathed if you can keep your numbers where they are right now by making the interventions strongly and positively now.
Thank you, Brian. So Dr. McDermott, il a répondu d'une différente façon. and قال لك باللي yes النمبر تاع الكا في الجزائر راه لو، بصح قال لك هذه سي اون اوبورتونيتي باه نديروا لا كارونتين والسوشيال ديستانسينغ ونديروا الهاند واشينغ pour contrôler la propagation du coronavirus. ومن بعد il a pris un exemple في les États-Unis when on est late, on a كيما l'Italie, on n'a pas contrôlé, on est actuellement faced by beaucoup de challenges to control the virus parce qu'on n'a pas agi à temps. So في الجزائر ان شاء الله هذه مي كاين غير ان شاء الله نتمنوا كاين غير 400 كيس ولا دون سو جون باه ان شاء الله هذا سي ان كاين اوف بوزيتيف بوينت. هذا حاجه غادي تدفعنا باه نديروا مور in term of hygiene and quarantine and isolation, social isolation كما يسموها. The next الثاني السؤال الثاني ما يشوف هنا بس I'll see if I get on the phone. I can see it on the screen. Was it? Okay, so now it's fine. So what the number case? So السؤال الثاني, the second question, are the influence of epidemic situation in the BR will correct me. So fine, the question, what are the influence of the pandemic situation on the liberal healthcare worker, such as our brother, he's a GI doctor, gastroenterologist, and I think I understand that he's in private practice, and he said if I understood well, what's the impact the virus pandemic?
Right. So I think as a specialist such as a gastroenterologist, the risk is of really you becoming infected and which would remove you from being able to help other your patients at a time when they need it, as well as the concern that a healthcare setting is a common place for the spread of disease. So sick patients come to see you and they either get you or your staff sick, and then you end up being the source of a cluster to infect other patients. And so those are all things that we did not go into medicine for. So we want to limit ourselves being part of the problem. And so that's why in the United States, there's been a big push for specialists to defer any elective procedures and minimize any routine office visits that do not need to happen at this point, so that patients at risk do not, have that social contact with their physicians now if they don't have it, and to move those visits if needed to either video or telephone visitations, just like we're doing here. These same kind of technologies can be set up with your patients so that they can stay at home and ask you questions, you can see them. Limit the patient doctor contact, physical contact, to only those patients who have real immediate needs that can only be handled, in a face-to-face and hands-on situation.
دكتور براين ماكديرموت قال بلي فور الهيلث وركر كيما حنايا دي ميدسان اوني ات ريسك باه نكونوا فيس à des malades qui sont coronavirus positifs. Ou parmi les moyens اللي نقلوا هذا الريسك number one نجموا we have to make sure that يكون عندنا face mask والgloves hand hygiene والsocial distancing كيما كاع لي جون. وثاني في لوبيتال في ساراتوغا هوسبيتال شنو نديروا دروك كاع لي مرضى اللي عندهم في الاوفيس مثلا اللي عندهم فولو اب فيزيت مع لا نيفرولوجي او كارديولوجي قلنا لهم بلي ما يجوش رانا نديروا معاهم تيلي ميديسين اتس نيو كونسيبت هنا في this area. في quelques jours on a pu installer des moniteurs ودروك باه المرض يجي عندك الاوفيس دير معاه تدخله في الشكادل في التيلي ميديسين ودير معاه كونفيرونس كول كان دي فيديو غير بالفون تاع ايباد في الفون وحنا نديروا معاه نديروا معاه هكا كونسلطاسيون ميديكال. وهذه وان ثينغ يو كان تنجم دير معاه ثاني تليفون انترفيو دير ان كونسلطاسيون بار تليفون وسي هنا في لي ستازوني سي ريمبورسي بار سي بايون لاسيورونس بداو يخلصوا ايزون كومونسي على كوفرير هذو لي سيرفيس. سو هذه وان ثينغ. ثاني حاجه درناها كاع لي شيروجي qui ne sont pas urgentes, on les a postponées, on les a reportées. Donc, ce qui fait في l'hôpital دروك أن نديروا غير l'urgence وهكا pour ne pas exposer le healthcare worker وثاني pour to save les PPE, to save les masques ou les gants, les surgical gants وثاني les gloves and وثاني on se prépare pour the surge because there is many كان overload تاع لي مالاد في نيويورك لي زوبيتون سون ساتوري اون سو بريبار دو كاين دي مالاد غادي نسلوهم من هنايا من نيويورك يسلوهم هذو الاريا. ودكتور ماكديرموت كان بارمي لي جروب اللي كان يهضر مع الجوفرنور دو نيويورك جوفرنور كومو هاو تو بريبار فور ذا سيرج وعندنا ان بلان هنايا. دونك الهيلث وركر ينجموا هما ثاني يديروا سيم بريكوشن كل مالاد. Brian, next one are the prognosis. What are the prognosis of ventilated patient? شتا هو البروغنوزيس نتاع لي مالاد كي سون في العنايه ويتنهتوا بالفونتيلاتور. براين. Hello?
He's severe enough to be ventilated, to be on the ventilator. Your prognosis can be poor, upwards of 50%. And again, the risk factors being the older you are, the less likely you are to survive. And then your comorbidities, heart disease, diabetes, underlying lung disease, immunosuppression are all risk factors that compound that. In fact, like we said, ventilator limitations in terms of the number of ventilators relative to the people who need them have proved to be a crisis in Italy. They've made very harsh decisions in terms necessary, but harsh decisions in terms of who's going to have access to the ventilator if there are not enough. Such as just making cutoffs, such as if you're older than 80 years old and you need to be on the ventilator, they're not going to put you on the ventilator so that somebody younger who has a better chance of surviving has access to that level of care. In the United States, we're not doing that, but we are having those kind of discussions in our hospital right now. So, for example, we are putting together an ethics committee to help decide what are the criteria of if we were to run out of ventilators and had to make those tough decisions of not having enough ventilators to give the care to those who need it, what would be the criteria of risk stratifying patients so that those with the best prognosis would get the opportunity to be on the ventilator, and those who would have to make those decisions to say, no, we're not going to be able to provide that service, we would do that. So again, it's no, we would not have such a arbitrary cutoff. There would be a much more risk stratified, patient specific decision making with a committee of educated people who all give their input to make those kind of decisions, not one person doing it.
Thank you, Brian. So الجواب هو يقول لك 50% des malades qui sont ventilés COVID-19 positifs اللي عندهم كورونا فيروس sont positifs وسيرتو اللي كان عندهم des comorbid conditions اللي عندهم diabète, l'hypertension, ils sont cardiaques, insuffisance rénale, 50% عندهم الوفيات. So le taux de mortalité est très élevé. وثاني وهدر على the currently دروك في نيويورك ستيت في نيويورك سيتي كاين 3000 فونتيلاتور و ils ont besoin de 40000 فونتيلاتور 40000 اي سي يو باد. كاين شورتاج تاع لي فونتيلاتور. لوبيتال تاعنا هنا في ساراتوغا كاين كوميتي ايثيك كوميتي ديتيك اللي كومبوزي دكتور براين ماكديرموت و certains physicians وباه au moment venu and si besoin s'il y a un besoin lorsque les maladies jouent l'ICU ou le ما عندناش un ventilateur, on doit choisir d'offrir le ventilateur à des malades qui ont un less risk of dying اللي عندهم better prognosis بالك mieux. So donc on va نديرو ريسك ستراتيجيك نديرو on va différencier بين لي مالاد اللي عندهم بور بروغنوزيس ولي مالاد اللي نجموا ان شاء الله يريحوا و on va allocater les ventilateurs en fonction de ça. So ما درناش بصح خدمنا على بروتوكول and so that in the same regard في الفنتيلاسيون درت يامس درت فيديو هنا في ساراتوغا هوسبيتال مع الريسبيراتوري ثيرابيست ودرت وفي الفيديو 12 مينيت فيديو راها في هنا سايت INS سايت وهذه تقول لك how to comment ventiler plusieurs malades avec un ventilateur. So عندك هنا malade j'ai describé le process slowly بالعربيه بالفرنسي slowly هكا وكل واحد ينجم يفهمه وفهمتكم على how to do it وهدرت على البوبليكاسيون كا ايتي فات وحاليا في نيويورك بريسبيتيريان هوسبيتال ils ont commencé في نيويورك سيتي ils n'ont pas de ventilateur, ils ont commencé à ventiler deux malades avec un ventilateur. Qui m'a
I'm sharing the video but with no audio so people they can see what you're talking about.
Yeah, so you can ان شاء الله تشوف هنا داونلوديها وترسلوها للبلاد الخاوف ما في الجزائر وقلت لكم الكونيكشن وين تصوبوها وعندنا هنا شويه عندنا لي كونيكشن هنا نجم نرسل الخاوه ولا you can be creative. هذا لو مومون تاع to be creative. You can't just say او ما عندناش احنا نخلوا المرض يموت. احنا عندنا 40 مليون مش غادي تخلوا المرض يموت. So you have to be creative وتشوف الحاجه زعما بالك انا خاصك ماسون ولا واحد اللي نجم يدير لك هذيك كونيكشن ولا واحد انا انجينيور بصح تنجموا تندار فوالا وفيديو اللي اكسبليكاتيف. So هذه هي السؤال و you can access this في السايت INS ولا راه في اليوتيوب وتحوسوا عليها ان شاء الله ودرتها هذه امس مع ريسبيراتوري ثيرابيست. So next question اخ بوزيد what I'm not seeing the question.
Dr. Rashid, maybe I will share the last question and maybe the time is up. Looks like the half hour that we extended. We don't want to take any more from your time, but we always, inshallah, can get together next week. Maybe if we can make this a weekly thing. I'm just looking for my screen that I can share. Okay, sorry for that. So my two kids, and they were not planned part of the
ما
plan.
شاء الله.
Okay. Yeah, thank you so much. These are the questions. Maybe we take one last question, doctor, before we can wrap up. تفضل أستاذ. You can see my screen, right? Or Dr. Brian, maybe you can pick one question.
Okay. So the next question is, what local materials can we use to make good masks, FFP2 or FFP3? And so, again, I think I'm not sure that you have access to the materials that go into making, an N95 quality respirator mask, which is what FFP2 and 3 largely refer to. And again, my answer is, in general, that is not what you need to keep yourself and your other healthcare workers safe. So if you go back to the Atul Gawande New Yorker article that I shared in the presentation there, the things that work are a simple surgical mask in most situations. Again, the risk of aerosolization, except under the most significant conditions such as intubation, largely will not require a N95 to keep you safe. I know there's conflicting. The guidelines around the world are in conflict with the data. So the disease is largely, as I said, a droplet spread disease. The risk of aerosolization is not zero, but it remains in almost all circumstances quite low. So in almost all circumstances, a simple surgical mask will be sufficient. And despite that, all the guidelines all say, although the risk is very low, wear an N95 mask, if available. And so that puts everybody in a very difficult situation, because although on one hand they're saying the risk is very low, they're saying to wear a mask that assumes that the risk is very high. And that creates a lot of angst and anxiety among healthcare providers, and really is unfair to healthcare providers by not being consistent with what we know about the disease. So again, I think the proof is really in the Singapore and Hong Kong experience, where they did not make high-level respirator protection one of their core principles, and yet they had no healthcare transmission of infection. So they are the proof. Although everyone's saying that's the standard, in practicality, so focus on having simple surgical masks as your standard, and you'll be able to keep your patients, yourself, and your staff safe.
سو الجواب تاع الدكتور ماكديرموت هو قال لك سي كان ان كونفلي بين لي ريكومونداسيون وش لي جون شام يديروا. قال لك لا بلو if you go back to the publication that was published يهضروا على سنغافور الاكسبيرينس سنغافور and هونغ كونغ. قال لك سي ان سامبل ماسك وثاني the hygiene and social distancing. قال لك هذه كان عندها ان ايفي بوزيتيف. وال N95 ماسك الماسك اللي يوتيليزي وان مالادي فونتيلي. قال لك كاين ان ديبا و سي با كلير comment adresser la situation, but still تروح again to the publication اللي كاينه هنايا في الاكسبيريونس تاع هونغ كونغ وسنغافور. ils ont utilisé هذو الماسك غير في لي زانتوباسيون، في لي كون وين كاين الريسك تاع الهيلث كير وركر بيكون اكسبوزي وين يدير ان بروسيجر المالاد كيما الانتوباسيون. بصح سي ستيل سي با ديفيني سي با ديفاين. انا بيرسونيلمون من نشوف ندخل مالاد وبوزيتيف ولا رول اوت ولا يدير تيستينغ بنشوفوه ندير ال 95 ماسك. بصح في الفلور من راني دروك ندير ماسك سامبل، ما كنتش ندير ماسك بصح دروك راني ندير ماسك. ولاك دكتور براين ماكديرموت قال لك سي با هذه لا كونتاميناسيون سي با ايروسول سي زي دروبلت سي المالاد يتوشي. هذه كان في لا ميوكوز بالهاند تاعه يتوشي فمه ولا عينيه، ومن بعد هذوك لي دروبلات يتوشي الطابله ولا الكمبيوتر، ومن بعد يجي واحد اخر يشوف il va se contaminer. سو على هذه الهاند واش وكي دير الهاند واش كاينين تكنيك، كاينه فريمون تكنيك كي تغسل يدك وكا. سو هذه فيري امبورتانت تو امفاسايز باه تقولوا الشعب الخاوه ولشعبنا. اخ بوزيد.
So much, Dr. Dawi. Thank you so much, Dr. McDermott. It was really a pleasure having you. I know that the list of questions is really long. القائمة تاع الأسئلة طويلة. Dr. McDermott and Dr. Dawi, we will send you an email with the list of questions. If you can please answer them, and we can post them on our website. My last maybe call for our guest, please go to our website and register. I'm sharing the place where you can go and register, so we can have all your emails. Because I know what happened. We sent an invitation to one doctor. Some of you sent it to, وكان الإخوة اللي بعثوها لأصحابهم. فهذا هو الموقع تاعنا اللي تقدروا تسجلوا فيه: www.algerianscientistforum.org. ولا تقدروا تروحوا لجوجل وتحط Algerian Scientist Forum، ولا تحط الشبكة العالمية للعلماء الجزائريين بالعربية في جوجل، رجلك بعدين تروح members, become a member, you send us your information. We will have the same thing. I suggest we will have this. I think the discussion is long, and the pandemic is taking looks like it's taking longer than it was predicted. So inshallah next week we will have the same call. The invitation is for all of you. Dr. Brian, please, you can always be part of this, and we will always learn from you. The rest of you always can, inshallah, receive and check our platform, our emails for next events. Dr. Rashid, I will leave you the last. I know that's an emergency call. We'll leave you the last word, Dr. Dawi.
بارك الله فيك اخ بوزيد. So I will start. نبدا first to thank Dr. Brian McDermott for the excellent presentation, and we all the Algerian scientists, all the attendee, and they are from Algeria. They're doctor and pharmacist from Algeria and France and different parts of the world. They want to thank you for being with us on the weekend. And I know, Dr. Brian, that you have been working so hard, and in the past people calling you all the time, but you find the time for us. And that means so much for us. والإخوة الجزائريين الأطباء واللي scientifiques. And je pense هذا c'est le moment. Le coronavirus, so c'est une pandémie. حاجة زعما c'est un désastre. بصح في كل حاجة كاينة opportunity. في حاجة مشكلة في البلاد كاينة opportunity. الشعب تاعنا راه يسوفري، وفي الشعب تاعنا راه يسوفري في كل المجالات، وحنا كمتغربين رانا نعانوا، رانا معاكم. وخص كاع نتحدوا ونجوين هذه البلاتفورم ونخدموا في رحبه. والنيه تاعنا هي البلاد، النيه تاعنا الشعب البسيط الجزائري، الطالب، الاستاذ، الممرض، كل انسان. ان شاء الله هذو الحاجات البروجي نديروهم بيناتنا غادي تولي عليهم كما بلدان العالم. كان عندهم دي لوبي لي زاندي لي فرونس، كان عندهم دي لوبي في الخارج. حنا ان شاء الله غادي نكونوا اللوبي نتاعكم نتاع البلاد. والسلام عليكم. Brian, you want to say something? Brian.
I will just say thank you, and it's been a privilege and an honor to be here with you today, and I thank you very much.
Thank you, Dr. Brian, and have a nice weekend and be safe.
You too.
الله يفيك حاكم خويا.
استاذ يوسف ما عرفتش نسمعوا فيك. يوسف.
هذه بالنسبة لي بربع علي. هي ب6.30 فهمتي؟
So sorry, somehow I think I was muted. So I was saying thank you so much. Have a good weekend. يعطيكم الصحة الإخوة من الجزائر، من أوروبا، من العالم كامل اللي كنتوا معنا. إن شاء الله سجلوا معنا ونشوفكم في مناسبات أخرى، وبكل بليس راح نشوفكم إن شاء الله في الجروب تاعنا تاع السوشيال ميديا. سامحونا، بارك الله فيكم ويعطيكم الصحة. Thank you so much.